Why don't we go ahead and get started? Welcome everyone to our DMICE Thursday conference. And we have a guest today from a little bit down the road, down I-5 in Corvallis, Dr. Denise Hynes, who someone who I've known a long time, back to when she was at University of Illinois Chicago, which is actually where I'll be next week. She also knows David Dorr and maybe some others in the room. And she was at UIC for a long time and then relocated to the relatively new College of Public Health at Oregon State, where she's a professor and is director of the Health Data and Informatics program in the Center for Genome Research and Biocomputing. And I was actually down there myself a few months ago, and it's really interesting what they're doing and how they use like DNA for everything to track species and things like that. It was fascinating. And I gave a talk, and there was a nice turnout. That's why I always get a little nervous when we don't get a good turnout, but we got a good turnout today. So a few things about Denise. She's actually originally trained as a nurse and then pursued a doctoral degree, a PhD in public health at University of North Carolina, Chapel Hill. She's done a lot of health services research. She's been involved with the VA. In fact, she continues to be involved with the Portland VA here, so she's up in Portland not infrequently. And she's going to talk today about using EHR data in research both from the VA and PCORI. So take it away.
Thank you. Thanks for having me. So I was on a call just before walking over here with colleagues in Chicago, and 32 degrees there. And there's not a whole lot of green. Every time I get on the phone with them, I feel like I talk about the weather all the time, and I have to stop doing that. So I've been here in Oregon now for just maybe 14 months, and I still don't know where everything is, but I'm getting acclimated, and everybody's been quite lovely. So if I haven't met you yet, hopefully you'll say hi at the end today. So I kind of went in the middle of the road with my topic today. Not sure, so just to be clear, so I don't personally do informatics per se. I don't develop software. I'm an ardent user. So the kind of things that we're doing at Oregon State are really things like getting RedCap set up and developing, a whole package around, helping users. They didn't have RedCap. And then getting folks to understand some of the tools that the CGRB has there. And so what I was going to talk about today was really more about some of the work that I've been doing, mostly, relying on electronic health record data. And then I dug into some of my VA and PCORI research. And this kind of builds on a lecture I did last summer at ARM. Actually, David was part of it too, looking at some of the methodologies that PCORI had put out around data quality. So I'll give you some examples around that. Okay, test. So my classic disclaimers, both PCORI and VA have funded this, as well as NIH. In my previous life at UIC, I was also the lead of the informatics component of our NCATS program there. Yes, building clinical research data warehouses, right? So here's what I'm going to talk about today, and I promise I won't knock this theme over the wall today, but I'm going to tell a story. I'll talk about just some of the conceptual issues around working with electronic health record data. What story does it really tell or not tell? I'll make some reference to some of the fitness of use concepts. I'll also talk about, some of the strategies that are available to address, focused mostly on the missing data issues with electronic health records as far as research goes. What can you add to the story when information's missing? And then implications for dissemination and information sharing. So, telling the whole story at the end here. So before I dive into this, just give me kind of a, sense of, who you are. you know a little bit about me. So how many of you are using electronic health records either directly or derived on a regular basis in research? Okay, so about maybe a good healthy third. Okay. How many would like to use electronic health record data in their research? I'm telling you, my interest in it, especially in the VA, with all the changes we have going, they're changing our electronic health record. We're all thinking about, okay, let's do some prospective data collection. Okay, so good. So let me tell you a little bit about kind of like what the story is with electronic health records. And I'd like to also, I'll try to pause periodically so you can ask questions during the presentation. So electronic health records, you know, fabulous resource for those of us who are clinical and we know the process that goes on and all the data that's gathered. And it's, you know, frankly, you know, a huge asset in the VA where we have, you know, this, you know, phenomenal data across, you know, I can't even count anymore. We always say about 150 medical centers, but, you know, there's all these, you know, if you will, pods around them. I've lost track of how many there are using the same information system and basically, you know, porting that data into a national corporate data warehouse. It's phenomenal, but it's designed for patient care, right? So the kind of things that I think about doing, researchers think about doing, are not necessarily the primary purpose for which it was constructed. So, you know, it has its limitations. And these limitations, they apply to wherever they're extracted to, and it actually may be, you know, the problems and challenges may actually be increased because of that ETL extraction, translation, transformation, loading process, or any of the business rules that they use. You know, the kind of thing that I paid attention to a lot in my research is, you know, the level of missingness and how it affects research. There's obviously a lot of other data quality issues with electronic health records. I'll just touch on those today, but I'll focus mostly on just sort of missingness, if you will, and some of the strategies to address some of the missing data. And like I said, I've dug into some of my VA and PCORI research, all of which is now published. So I'm pensive about that because I just want to make sure that that's cool in the YouTube, and then talk about some of the issues around dissemination. So this little cartoon, I kind of liked. I adapted it from a paper that I saw Wells and colleagues had published, and it just kind of gives you a sense of, without showing you, you know, an actual electronic health record and what they look like. It's sort of interesting because electronic health records, you know, for those of you who use them, it's not like one tool. It's about 5 tools open simultaneously. And, you know, some things may be all nice and contained, and there might be a lot of well-contained structured data. And then there's other pieces that are legacy systems. OHSU uses Epic, right? I'll bet all of your tools are not Epic-based, right? So there's legacy systems probably in lab or maternity, and those things have hooks into, you know, whatever Epic's doing. So you can imagine, and then there's billing. Epic probably has billing here, but not everybody does. But you could imagine, you know, there's this whole cascade effect of all the data that we think of as electronic health records and the legal record, but what goes into that can come from many different places, so it's not one thing. So, you know, the concern is that, you know, you're following patients or you're following populations of patients, and, you know, some of the information is just not there. You know, why don't they have that data, that variable that you really want? Marital status. You know, that's just a really important one. Or where somebody lives. Well, think about that. Is that something that is part of the clinical care process? Maybe sometimes it should be. You know, as opposed to a critical lab value. So the kinds of things that we like to use it for, especially some of those social determinants of health, which you're hearing a lot about, may not be there, even though there's a field there. But, you know, even for some of the very clinically relevant information, diagnosis, a lab result, you know, it still might be missing for some reason. So, you know, some structured data could be missing. You could imagine, you know, some issues around the fact that a lab was ordered, but the results aren't there yet. So it looks like the results are missing. Or, you know, sometimes data are missing and we assume that it's negative. So, you know, a lab test that doesn't indicate a positive result, so do we assume that it's negative, or what is it actually? And then there's other things, you know, sort of in the middle here that are, you know, missing and irrelevant, maybe to the care team, like, you know, whether they're married or not, or whether they got their health insurance, you know, updated. It might be really important to the billing folks, but maybe not necessarily to the clinical operations. Those are aspects, obviously, that if you are using these data for some secondary purpose, like to study social determinants of health, or lab results, or some of these other metrics, you have to think about ways that you might have to, quote, fill in the blanks. So these yellow boxes are just some ideas, some, you know, approaches that are sometimes used. So when you have missing structured data, you know, it might be that, you know, the data just haven't been brought in yet. So there might be some mechanism to import external data. Patient goes outside your system, and maybe the laboratory results are, you know, at the lab, and they need to be ported over. May only be in a fax form, but, you know, you might actually get the result. And sometimes in research, we might have to actually impute. You know, I still call it guessing, you know, what it is. You know, when you go to the top, you know, if there's, you know, there's issues around why data are missing, and you're not sure why it's missing, or it's truly absent, you know, you might have to use some of these alternative sources for data. And there could be all kinds of things that you might do. But in addition, you know, there's statistical adjustments that sometimes you can do that I suppose fall into the category of imputing. You can have, you know, missing data completely at random, missing not at random. I'm definitely not going to go into all the stats around it. Some of you probably know this a whole lot better than me. But there are definitely aspects that are important in considering, you know, what the electronic health record data that you're working with represent for your particular research question. My colleagues out there have published a lot in eGEMS. Is a huge journal that has a lot of the data quality frameworks. There are several others, and I know some of you have also published a lot around data quality. I pulled this one up just as an example. I think I've come across about 15 different data quality frameworks now. This is one that actually colleagues at Columbia had published back in 2017. You know, it just kind of gives you a sense of the different kind of information that, you know, are assessed when you're thinking about data quality with electronic health records. You know, do the data agree, for goodness sake? You know, if you see it in multiple places, do the data agree? If somebody is diagnosed with diabetes, you know, does it actually agree with the lab results that you're seeing? And you can imagine the examples. You know, are the data actually true? Are they plausible? This is where I say, you know, do they make sense? You know, does it have face validity? Are the data complete? You know, if the example that I just mentioned, you know, you want to see that if a lab test was ordered, you know, a month ago, you'd think that, you know, sometime within the last month there should be a result there. So what's going on with that? You know, how current is it for the situation? You know, if you're doing a study where you know, time is an important component, you know, if you're looking at the currency of particular values, you know, that could be really important. If somebody's supposedly diabetic and the latest lab value is, you know, pretty long ago, you may question whether they're really diabetic or whether the lab test was really relevant. And some of this, you know, can be obviously related to, you know, some of the algorithms that we now have. I just sat through a conversation with a new tool looking at all these risk stratification things, and, you know, I think I saw about 10 different models integrated into one really cool web app. But I really wanted to see the algorithm that was behind it to grab and update all that data on a daily basis. And so, you know, we start to think about, you know, not just, you know, an electronic health record, one piece of software, but how they all work together. You know, and some of these concepts are, you know, really you think about the intrinsic aspects of the electronic health record. then there's contextual, and then ones that just kind of, they're representational. Fragmentation is a representational concept, they introduced here. So you want to see that, it's, the data sometimes can be represented in multiple places, but it sure would be nice if it was in one and you had one place to go for that information. But we know that in electronic health records, these things pop up all over the place. And, you get these issues with, sometimes inconsistency when they're in multiple places. And then are the data in some sort of structured format, or are they in unstructured means? And we still have a lot of that. So you think you want to have information about the person's lab values when they went outside the system, but the only way it's available is if it's in, buried in some note that, on a consult somebody interpreted when they did, the MRI or the surgical path report, and it never makes it into a structured field. And believe me, I've had to dig through those. So all those components, may comprise the electronic health record, and there are aspects that you really have to think about, how you're going to structure your research project in order to address it. Yeah, go ahead.
I just want to say one thing. Dr. Weisskopf did that work as a PhD student, but she's actually at OHSU and actually sends her regrets that she wasn't able to make it today.
Cool.
But
yeah,
I'm sure she's thrilled to see her work being expounded in such great detail.
Well, I would love to know if, when she actually did this paper, and, there's a bunch of other Columbia people on there, and I know actually several of you actually provided the subject matter expertise in reviewing the concepts. And it was interesting to see how that expert review went, and that's what's actually shown here. And what I have in here is that there was a lot of disagreement about these concepts. And not to pick on this particular framework, but all of the frameworks, there's still a lot of discussion, I'll say, and respectful disagreement about what are some of the most important aspects. And so much of it depends on what you want to use the data for. PCORI actually came up with some new recommendations, actually right before we did this presentation on the panel last year, around their methodologies. And some of it does address how to strategize what approaches they would like to see for addressing missingness in electronic health record data. So I'll talk a little bit more about that. What I have, boxed out here is the red under data quality constructs, complete, correct, current. The one area where there was the most agreement among the experts was, this concept of whether the information is actually correct. And some of the aspects around, completeness and currency, there was a lot of disagreement when the experts take a look at this. Are the data at a patient level sufficient for each patient? Well, depending upon your research question, experts may disagree about how important that is. Are the variables sufficient? Do they have enough data points for each variable? So if you're looking at things over time, you may have more concern about that. If you're doing something in a cross-sectional nature, that might be less concerning. Or if you're looking at, a value to represent a year, that may be less concerning. Again, so much depends on what your research question is. I would encourage you, if you're contemplating, for those of you who didn't raise your hand about using electronic health records and you expect to rely on them, please consult some of these data quality frameworks, because I think they shed some good light on how to consider what data you should use and approaches too. So let me just kind of go to sort of a very practical approach and thinking about, are these data suitable for your research questions? And I just have some examples here that could be relevant. Identifying cases, for a particular study, observational study or prospective. They can be, electronic health record data can be extremely useful for a recruitment list. We've done a lot of work in the CTSA world around, trying to build tools to make that easier, and other places, or building cohorts or use cases, if you will, on the presence or absence of specific variables that the electronic health record is really used for. So usually diagnosis. Procedure codes I like to cite because it's one of those variables that we have become to depend on so much for billing that they tend to be very reliable because they have to send those data out to CMS and other places and insurers. But, you know, they're not always perfect either. But, you know, if you're identifying specific events, use of new medications or procedures, processes linked to outcomes, you know, again, when you start to get into process kind of work, it can be a little bit murkier. Or if you're trying to sequence things, you know, a hospital discharge and then looking to see what happens after that. Is it in the system? Does the medication actually get prescribed and then, you know, picked up? And then the whole issue of patient compliance obviously is you know, one of those unobserved variables in electronic health record. Vital status, for example. I know in the VA we have a pretty good system for keeping track of, you know, vital status while people are experiencing some sort of healthcare event. But once they're outside of the healthcare environment, you know, you don't always know what happens to people. And I'm not sure on any electronic health record system that may or may not be there. I was at the Healthcare System Research Network, used to be the HMO Research Network, on Monday. And so many of them now are talking about ways to integrate mortality data with electronic health record data from the various states and from National Death Index, because they don't necessarily have those modules, and they have to go outside to know if, you know, their patients actually might have expired, you know, at home or what have you. So again, you may not be able to depend on the electronic health record for vital status. Characterizing subjects in a study. So, you know, you think about it, you want to rely on those social characteristics. Again, you have to think about, are those characteristics that you're interested in really tied to clinical care? I used to think that, you know, especially with like laboratory values, you know, there's different ranges for race and ethnicity. So you would think that that would make missingness really low on race and ethnicity. No, it doesn't. It's a very highly missing variable, and I'll talk about an example from that. Process measures, you know, if you're looking at admissions, discharges, visits, transfers, those can get a little bit murkier, but usually workload is pretty good. But if you're looking at, again, any kind of process that might be a little more tangential, you know, trying to track those kind of things at a patient level may be a little more challenging. You know, and then outcomes. If you're looking at outcomes that are within the electronic health record, you know, you may know that somebody had a readmission within 30 days if the system keeps that, or that they had a subsequent admission, but you may not know what happened in between unless there was some kind of a healthcare contact. So this is just, you don't have to really see the details of this, but this is from a workflow from a PCORI study that I led, focused on dialysis patients. Dialysis patients, they have a lot of contact with the healthcare system. And our study was looking at putting an intervention in place to improve access to primary care. So we were following patients for 18 months, and it was a mixed methods data collection. A lot of primary data that we collected, REDCap, the whole bit, interviews, focus groups, but dialysis patients have a lot of labs, they have a lot of healthcare encounters, so relying on electronic health record data for that. So we really needed to have that. This was just a workflow for, you know, how the patients flowed through the system and what we did, and we were really relying on the electronic health record data. But the reality is, you know, some of the EHR data fields don't get populated, even some of the lab tests. Why? In our patient population, one of the sites we had, they rely on their dialysis equipment for some of the lab values on the fly, and then they load it up into their data warehouse. Well, they miss some, you know. So, you know, every system is a little bit different. And then another issue is that, you know, some value fields just aren't valid, you know. BMIs that are, you know, just out of this world, or lab values, you know, hemoglobin A1C of 48. Do you really believe that? Maybe. And, and then, data extraction challenges, sort of more the logistics. The data are in the electronic health record, and you've worked out a process, a workflow with your, data stewards and your data experts. You've got your data use agreements, et cetera. And, the technology is just not working, no matter what you do. So I want to pause here because I want to dive into a little bit of some of the examples and some of the experiences I've had and some of the fixes. Any questions so far? Okay. So this is another project that we got involved with. This is one of my VA studies. In this particular example, we pulled I think it was a 10% random sample of VA patients from the corporate data warehouse. VA's corporate data warehouse relies exclusively on feeds from the electronic health record. And this is where we are exploring, the completeness of race and ethnicity data. And we kept stumbling on this in every project that we had and trying to think about ways that we could address this. We were doing a lot of work with both the Department of Defense, all the veterans, have some kind of contact with the DoD, you would think, but they don't always have a healthcare experience with the DoD. Anyone over 65 who's in the military will have some kind of Medicare record, you would think. And so we hypothesized that we might be able to, we were having, missing VA electronic health record data, on the order of like 50% in some places. And it was just, amazing to us that we had that kind of a challenge. And other places, it was really good. The reason it's missing is because, anyone want to guess? It's captured at the time that a patient is visiting, having an encounter with the admitting clerk or the outpatient clerk. And it's self-reported, which means the person has to ask them their race and ethnicity. And admitting clerks and outpatient clerks don't like to ask that question. So if it's already there, they don't ask it. And if it's not there, sometimes they ask and sometimes they don't. And when they do ask the question, sometimes it's hard to answer the question. People don't feel like they fit into any particular bucket. And, so it's sometimes, a person may have one response and the clerk hears something and it doesn't fit into their category and they have to check some box. So you can imagine, that sort of encounter. A lot of times it's just not asked. So that's the reason it can sometimes be missing. So what other data sources is what we looked at? There must be an alternative data source. DoD must have something. Medicare must have something. So this particular table that I pulled up just shows how we use the Medicare data to basically fill in the blanks. And the column that I have highlighted here is the positive predictive value of using, what we compared is Medicare data to the VA's reported information. So how was the data that was there, and did we actually fill in any blanks as well? So by adding Medicare data, we actually were able to improve the completeness of the race data by 75%. It worked really well for patients who were 65 and older. Some people can be eligible for Medicare for disability reasons younger than 65, so we may have captured some that way. But it was, using the VA self-reported race as the gold standard, it's clear that this is where I sort of get to the point about people don't, consider themselves fitting into these categories all the time. So what Medicare is reporting may not be necessarily consistent with what the VA has got. And so you can see at the lower levels here on the table, the positive predictive value goes down. Let's see if I can use the laser. Maybe not. anyway. You can see the lower row, positive predictive value, for example, for Asian Pacific, Islander, or other, is only 48.2, whereas for folks who are in the white, non-white, black category, positive predictive value for the VA's self-reported status was much higher. So we did better on certain race and ethnicity categories and less well on others. So what does that mean for your research? It means you really have to be careful about what alternative sources you use, and sometimes you're still not going to be able to fill in all the blanks. I'll just sort of share that the DoD data didn't help us a whole lot more. Yes. Yeah. For this table, this is not necessarily the category that people are asked, but that was our miscellaneous category for this table. Other questions? Another study that we were looking at was focused on looking at cancer patients and their use of anemia management approaches, primarily medications, erythropoietic stimulating agents, ESAs for short, or blood transfusions. You'd think that would be in our medical record. But we wanted to, look at both their hemoglobin levels, what are being, sort of monitored. Think of it as, for those of you who aren't clinically inclined, the hemoglobin levels are what triggers, some kind of anemia management. And usually the ESAs or a blood transfusion are the primary treatments. And it's what's used to monitor. And patients, when they have cancers, they actually can go down really pretty low and still feel okay. They can get, very exhausted, tired, stressed out, even before their hemoglobin starts dipping. But the reason we did this study is because they changed some of the guidelines around what should be the level that you start giving some sort of treatment. So a hemoglobin level, it's in every complete blood count. You can take, some subset of that. It's what, one of the main laboratory measures. And we actually had to exclude patients who were being treated for cancer and treated for their anemia who we couldn't find a hemoglobin level for. So we actually, of the 7,400 cases that we actually had to exclude almost 2,000 cases because as one of these situations where the lab was done, but we just couldn't find the result. Maybe it was recorded in a note. We didn't, look at notes. We tried to do a 10% random sample to see if we could find, what was going on. And we even tried to do a sensitivity analysis, revising the information, our analysis based on what we found in charts. It still was that, we found, we still were left with some missing data, but it actually helped us with, actually getting our manuscript published. We had actually found an alternative source, filled in the blank where we could, done a sensitivity analysis, and it didn't change our main outcomes. But those are the kinds of things that peer reviews are looking for. If you are excluding that many patients, how are you addressing it and how is it affecting your results? In the same study, we were also looking at, our main outcome measure was, are they getting these two treatments? ESA is a parenteral medication. It can be given IV or as a shot, as an injection. And blood transfusion, that's obviously intravenous. Well, as is, I mentioned, sometimes these different electronic health records have different treatments and different packages. Well, it turns out in the VA, ESAs are prescribed, but because they're parenteral meds, they keep track of those in a different place. So they're administered in the clinic. Most people aren't taking those home, like insulin. So trying to keep track of those things was not in the prescription order and they got a prescription fill. It's buried in some clinic note someplace. Some of it was structured and some of it wasn't. And then blood transfusion data. Well, that's over in the blood bank. You know, they keep track of when they, you know, when they dispense a, you know, a pint of blood to a particular patient. And where is it in the electronic health record? Buried in a note. So we actually had to exclude a good number of patients. I want to say there were about 1,500 that we had to exclude because we really didn't have an alternative data source. So, you know, this is one of those things where when it's your outcome measure, you really have to explain what's missing. And if you don't have, you know, a good alternative source, you know, you may be really in trouble. So it's really important to get another source. We actually had to go and do chart reviews. So let me tell you a little bit about just sort of, you know, you may think that, you know, in prospective studies, I've told you about some observational studies, retrospective observational studies. This was a prospective intervention study, so, you know, we were right there. You know, the electronic health record is very dynamic. We're trying to get information off of it. And like I mentioned, this is a study where we were studying dialysis patients. So we were getting information both from patients and out of the electronic health records, which were different at our two sites. At a dialysis provider site, they don't have full electronic health records. So what we're accustomed to in a large academic medical center that provides a whole complement of care, you know, it might not be what is at the community health center that's focused on behavioral health management, or in this case, a dialysis provider. They aren't including information about marital status or social determinants of health, let alone medications that are prescribed, because they don't dispense them. They track the services that they provide. And because of the nature of some of the facilities, they track laboratory values. But even then, in chronic kidney disease patients who are on dialysis, they literally have to meter the dialysis dose to their laboratory values. And they usually update that on at least a monthly basis, and sometimes week to week, depending upon how stable a patient is. So, you know, we thought our laboratory data would be, you know, 100%. And even that was not. Just to familiarize you, this list, you know, we only had 216 patients ultimately that completed in this intervention. But what I have highlighted here on the screen is the values that, you know, these are values that are really the ones that are important to, you know, manage dialysis dose, if you will. They're all laboratory tests. Some of them are calculated, like the URR, treatment adequacy, and this KT over V, which is you know, it has to do with you know, the volume, you know, that is critical in calculating the dialysis dose. Whereas something like parathyroid hormone, it doesn't dictate the dialysis dose, but they might need some kind of a supplement when those values change. So we really had to think carefully about, you know, what to do with the missing data, because we were looking at these values and, you know, for example, hemoglobin, looking at kidney disease quality of life. So you can imagine that if people are not getting the right dialysis dose, that it could affect their mental status, their physical status, and so we really wanted to make sure that we had good values for this. So we took a statistical approach, and we used one of the imputation methods known as multiple imputation using chained equations. I really appreciate they abbreviated that as MICE, not to be confused with DMICE. But you know, this was actually one of the methods that PCORI advocated as how to address missingness in EHRs. So fortunately, we had a really fabulous statistician who could implement this for us. And basically, you know, what you see is, you know, a sampling of some of our regression results that is, you know, without the imputation and with the imputation. They were thrilled that we did this. It really didn't change our results that much in this particular case because we had such a small sample. But I share this with you because it really does depend on the rate of missingness in your data. Why did we use this one instead of others? We actually talked about it a lot. There probably were some choices we could have made. We didn't like the idea of using like last observation carried forward. That just didn't seem the most relevant. And there's some other approaches. So we really sort of thought through, what these values really meant to us. In the end, we probably could have used any method, and it probably wouldn't have changed our results very much. And I mentioned some of these, just, choosing your methods for how to supplement, electronic health record data really depends on your research question, and your level of confidence in, some of these factors that may be important, in terms of congruence or, reference to a gold standard. An in-depth chart review may not be very practical, if you're dealing with thousands of patients. In our PCORI study, it was very useful. We were right there. In our VA study, we actually have can get access with permission to records across the country. But, when you're dealing with 150,000 cases, you're not going to do a whole lot of chart reviews, no matter how many students you have helping you. So sampling is really important, which is the approach we used. Additional data sources may still not be complete. You saw that with our Medicare data, DOD data. And so, you may still have to exclude cases, if it doesn't, meet your need. I really like statistical and imputation approaches, but you still have to be careful what you use. I personally don't have any experience with random forests, but I know folks like to use that. And there's some really good references that I've noted here. MICE is very popular. It's, can use it in a lot of different kinds of modeling, but I suppose you could probably do that with random forests as well. And last observation carried forward, you really have to be careful with that one depending upon what you're studying. For example, in our dialysis study, if we had a lab value in there that was from 2 years ago, it really would not be an appropriate one to use for a dialysis patient where you're dealing with a much more acute setting. So these are issues that you really have to figure out how to deal with depending upon your question. And then sort of the last part I wanted to talk a little bit about was just, making sure that, you share your story completely. And that's kind of where the limitation section in your publications come into play. But also can be more than that. So this is just an excerpt from one of our studies, and I think this is the one that we did with the ESA, the hemoglobin anemia management. We really relied on, in this situation, CPT codes. We thought that would really get us for administering a service, administering ESAs, a transfusion. But we are still not confident that that was the best fill-in, so we still had to exclude some cases. There's always that, we wish others would do this kind of study too. But there's also, I think, increased transparency around some of these issues. One, in the VA, for example, we've really partnered a lot. In the center that I used to direct when I was in Chicago, the VA Information Resource Center, we did a lot of partnering with what we call the operations offices in VA to, when we do research or when we came upon issues around some of these challenges with real high missingness like race and some of the lab values, we'd bring it to the operations side who would be responsive and actually would try to address it. They actually have we developed some really good partners in that way, and they actually addressed it in the corporate data warehouse. And I'm sure those are the kinds of things that you can do here at OHSU as well. I would have to say that at University of Illinois, it was a little more challenging. We, because we had a clinical research data warehouse that fed off of the electronic health record, we could get information and feedback back to, our colleagues who were the chief information officer and the chief medical information officer. But, from there it kind of goes. There's, trying to make those connections, when you're dealing with 5 different systems, trying to figure out where things are going to change. some sort of change management can get very complicated. But I'm still convinced that feeding back into our healthcare systems on the quality of their data, even if it's for research purposes, can help improve them. The other is, it can actually, also now where we have a lot more integrated tools that are bringing information together, some of the web apps. I just saw a demo this morning where they're bringing in, this really nice tool to bring information together and show you how things look, but it doesn't have any hooks back into the electronic health record. So if something doesn't look right, you have to take a lot of extra steps to kind of come back to it. But there may be ways to address that too. But also, even in your manuscripts, sharing that information, one, not only does it inform your next study, but it can inform others as well. So just some summary, and I'll wrap up in case there's questions. You really have to, ask yourself, is the electronic health record the best source of data for your study? And think about what other information you might need to supplement. I'm a big advocate of mixed method studies these days. Yes, even qualitative data, can be extremely valuable. And also for, some process measures, understanding the process. We're doing a lot of work now in care coordination and understanding that business process and does it even show up in the electronic health record or any of the tools that link into it, and how is really important if you're going to relate those processes to any kind of outcome. Try to plan ahead in preventing and monitoring missing data and trying to, get a handle on that before it's a problem. Considering statistical issues to address some of the missingness, alternative data sources we talked about, and then, sensitivity analysis has been around forever. And it really is important if you're considering, how to share this information with others in peer review and, frankly, in grant proposals, too. And finding ways not to report it only in publications, but in other venues. Your operational partners, your learning healthcare system likes to get feedback. So everyone has a story to tell. I'm sure those of you who've used electronic health records yourselves probably have both the positives and the negatives, and good advice for everybody. So I hope I've given you some good advice today and shared some perspectives. Happy to take questions.
Thank you for that. I'm curious whether any of the data warehouses you've worked with or projects you've done have involved oral health data that's come from dental offices and dental health record systems, particularly in whether they do have the same kind of missing data problems with the social determinants of health, or could be a good kind of complementary data source for filling in now that kind of dentists are doing more with care home.
Yeah, that's really a fabulous idea. I know I personally have not worked with dental records. In the VA, we actually have dental records as a module, but it probably I don't know if it has any additional information that would be beyond what else is already there. But I would imagine in the private sector that could be very, very helpful. Does OHSU do dental? Yeah. I'm telling you, the last time I was at my dentist, the amount of granularity that they have in those databases, he's got his nice little screen talking to you, and all I could think of is, wow, what's at the back end of that system? But I'll bet, I'm imagining, because I'm seeing this in, some of the small private practices, they may not own they may own the data, but they may be contracting with a vendor that keeps track of it in some kind of, consortium sort of warehouse. So trying to use that data for research, I could imagine, could be pretty complicated. Can you just say that again?
Sorry, Kaiser started integrating their dental and medical data because someone who used to be here, who is actually, I think, a doctoral student at your School of Public
At Oregon
Health,
State?
yeah, was actually
Is it
working
part
on
of EPIC, or is it separate, do you think?
I don't know. I just
Yeah.
know that they've been working on the dental medical integration, and that was a
Interesting.
project she was involved in after she left here.
Yeah, well, Kaiser uses Epic, so if they're integrating, it must be. But
Yeah.
Axiom is actually used by a lot of academic dental schools,
Yeah.
and I don't know the extent to which it integrates, but you know, this is always a challenge. Although if there were standards and people adhered to them, it might be less of an issue who the vendor is. But of course,
Yeah.
we're not there yet.
Yeah. I know with, you know, we worked with a dialysis provider, Fresenius, and they have pretty sophisticated network and data warehouse that they use for all of their systems. But it's, you know, it's only a sliver of care, but it's a pretty important sliver. Although these days now they're expanding into, you know, the full complements of care, so it's not just dialysis anymore. Other questions? How many of you are making use of the Oak Tree data warehouse here? Oh. I'm gonna get on that list, but I haven't gotten on the list yet.
Is there any hope? Thank you. This is great talk. Is there
Yeah.
any hope for aligning provider and researcher incentives to so that as this data is collected, it's understood to have quality, you know, for that research that the clinician might actually share some investment in to merge these interests?
Yeah, I mean, I think it really depends from institution to institution. I mean, tell me about OHSU. I'm still learning. You know, in the VA, they actually have a data quality office, and what they really, I was surprised in the VA, and I've been in the VA for a long time. I thought their data quality efforts would be sort of, if you think of data quality on a continuum, there's sort of front line when things are coming in or being collected, all the way down to the data warehouse. And as a researcher, we tend to focus on that end state. Well, that's where the data quality office focuses too. We were just stunned that that's sort of where their focus was. And I mean, they've been very responsive, and they will, get the message back to, who's ever managing the software, on the front end, but they're really not looking at it until it's already at the data warehouse stage. Mostly for identity management, which is huge, and fixing it there. So there's so much now, I think, is just, it gets there to the data warehouse so fast, maybe, they can fix it and get it back into, the front end. I'm not really sure. I was surprised that data quality wasn't being addressed sort of earlier on in the cycle.
Yeah, I'm not sure that. Actually, it's too bad Dr. Dorr had to leave a little early because he.
We'll ask him.
We'll
later.
ask him because I'm not sure it's a huge thing. I mean, again, one silver lining on this, is the new, proposed rules that have come from the 21st Century Cure Act that is starting to get a lot more prescriptive about, use, for example, of fire and various control terminologies. So there may be hope, but I guess the question though is if the data is not all being stored in the right place, and I don't know how much standards is going to help that if the data just gets put somewhere else. I guess maybe is it possible that again, maybe a kind of a researcher clinician collaboration, or maybe as healthcare organizations move in more data-driven directions because of accountable care organizations or whatever, maybe that might help to solve some of these problems.
It does make me a little nervous with so much attention on, machine learning and AI. There's been a couple, really major papers written, deep medicine and, some of the other ones that just came out in the last couple of months. It's the same mantra we've had around, bad data in, bad outcomes out. You have to have the right data to work with you know, in the first place. It doesn't matter what algorithm, AI, machine learning, ordinary least squares regression. If the data aren't there or if they're not representing what's true, you know, you're not going to get a good outcome. But it is fun to do all these, you know, different techniques. You still got to question whether, you know, the data that you're working with are legitimate. Well, thank you very much. Glad to be here.